Evaluation of the trauma patient, ATLS protocol, the Advanced Trauma Life Support, ATLS. It is the ABCs, the airway with C-spine control, is the breathing and ventilation, the circulation and hemorrhage control. It is the disability evaluation and checking the neurological status, and exposure and environmental control. Adherence to the ATLS protocol during evaluation of the injured patient in the emergency room improves the patient outcome and decreases the initial management errors. Evaluation of the multiple trauma patient is very important, and you start with the airway, always the airway. The first priority is airway control, usually with intubation if needed. Following intubation, the management should consist of ventilation and placement of chest tube if needed. Then vascular access, circulatory stabilization. Then you get the x-rays. And when you do airway control, you need to have C-spine control. Nasotracheal intubation has the advantage in patient with suspected C-spine trauma because it does not require hyperextension of the neck. You're going to evaluate the airway for obstruction. If you have a facial trauma and the swelling in the area of the airway, you probably have to do cricothyroidotomy. It's an emergency procedure used when routine methods of intubation are not effective or contraindicated. This is a favorite test question. The second thing is breathing and ventilation. This is usually evaluated clinically, but you can see the problem in the chest X-ray or arterial blood gases. This is some of the scenarios. Scapular body fracture and some rib fractures, and X-ray shows lung consolidation. The patient is tachypneic, or a patient was in a car accident and is in respiratory distress, and after emergency intubation, the arterial blood gases shows that oxygenation is poor with absence of breath sounds on one side, and you have resonance on percussion on the same side, and maybe tracheal deviation to the other side. There's a tension pneumothorax, and you will put a large needle in the second intercostal space, mid-clavicular line. The air is trapped in the pleural space between the lung and the chest wall, and it is compressing the lung and shifting the mediastinum. So you need to decompress the pleural space urgently, whatever by a needle, or you can put a chest tube. Watch out for a patient with a scapular fracture because that can injure the lung also. So if you have a patient that's hypoxic and is not getting better with intubation and you have decreased breath sounds on one side, you're going to put a chest tube because the patient has pneumothorax. And these are two examples of tension pneumothorax and flared chest. Then circulation. Circulation problem, you will see it clinically or radiologically, like in a chest X-ray or pelvic X-rays or CT scans. Circulation hemorrhage control means initiation of resuscitation, a direct pressure on the bleeding site or a pelvic binder. Then disability and neurological exam to see if the patient has neurological deficit. The exposure and the environmental control will be clinical evaluation to identify occult injuries and look for open fractures and rewarm the patient. What causes the patient death? It's usually the ATLS score plus the age of the patient that is used to predict mortality in a patient with blunt trauma and multiple injuries. So in the first few minutes, patient die from massive blood loss or from head injury. In the first few days from the injury, the patient dies from head injury. If the patient survived the first week of injury, they die later on from sepsis and multiple organ failure. And the question always comes, life or limb? Obviously, life is more important than limbs. And we physicians should strive to preserve the life and the limbs. And adherence to the ATLS protocol will probably help that. So let's take the secondary survey, which you do it 12 to 24 hours after the injury, will be complete exam and updates. The whole idea is when you do that secondary survey, it decreases the missed injuries by more than a third. We all know that about 10 to 12% of injuries are missed in the first 24 hours in patients with multiple trauma. So secondary survey is a good thing. Now let's talk about shock. Shock are different types. The first type is hypovolemic shock due to low blood volume. You can see that in the trauma patient, and you're going to give them fluids. The heart rate will increase. The most reliable early clinical finding for hemorrhagic shock is tachycardia. And you're going to give the patient 2 liters bolus of Ringer's lactate, followed by re-evaluation of the vital signs. So the patient will have increased heart rate, increased systemic vascular resistance, and the patient will be cold and clammy. Cardiogenic shock is a poor pump function, decrease the cardiac output, and you'll have decreased peripheral resistance. The one similar to the cardiogenic shock is called the obstructive shock, like cardiac tamponade, pulmonary embolism, have the same features. Another shock is called septic shock. You will have decreased peripheral resistance, vasodilatation. Then you have the neurogenic shock, which occurs in a patient with acute spinal cord injury. There will be impaired sympathetic response to the heart and to the blood vessels. There will be circulation collapse with hypotension and bradycardia. Mark the bradycardia, very important. Also, there will be decreased systemic vascular resistance with warm skin. The treatment is Swan Ganz monitoring for careful fluid intake, and you give pressors. Neurogenic shock is not a spinal shock where the bulbocavernosus is out and loss of all spinal cord function and reflex below the level of the lesion. Neurogenic shock is hypotension and bradycardia. The initiation of resuscitation is based on the degree of hemorrhage. So you will start by crystalloid, usually Ringer's lactate, 2 liters, with 2 lines, and then re-evaluate the vital signs. Patient may have rapid response, transient response, or no response. So if the patient have transient response, the patient is class 3 or 4. Then what's next? You need to give blood. The O negative will be given immediately. The type-specific blood will take about 10 minutes, and the cross-match blood will take 60 minutes. So if the patient is in shock and bleeding, what do you give? You give blood. Which one? O negative blood. What is the ratio? The packed RBC will be 1, fresh frozen plasma will be 1, platelets will be 1, 1 to 1 to 1 ratio. And that will avoid dilution thrombocytopenia. Hepatitis B carries the highest risk for viral transmission in the blood transfusion. So what is the class of hemorrhage? So we have 5 liters of blood. Class 1 is less than 15%. Class 2, we lose 15 to 30%. And the pulse pressure start getting narrower here. And class 3, 30 to 40%, which is about 1,500 to 2,000 blood loss. That's when you get the hypotension. So you have to lose at least 30% of the blood volume to get hypotension, obviously with some tachycardia and decreased urine output. Patient will be anxious or confused. Class 3 is hypotension. Class 4, you lose more than 40% of the circulating blood volume. The patient will be confused and lethargic. Class 3 and Class 4 may not respond to fluid resuscitation and will require blood transfusion. You must have adequate fluid resuscitation, period. If you rely on the hemodynamic parameters alone, you will miss subclinical hypotension. Hemodynamic parameters alone is inadequate assessment tool for resuscitation. Another point, you got to correct the hypothermia and coagulopathy. The terrible trauma triad is hypothermia, coagulopathy, and acidosis. These are life-threatening conditions that may become worse by surgery and by anesthesia. Another one connected to hypotension is the head injury patient. Patient with head injury can run into the problem of episodic hypotension intraoperatively, which causes significant increase in mortality. All efforts should be made to avoid hypotension during surgery. Patient with AP pelvis, you can put a binder, you can close the book, you can help with the hypotension and the hemorrhage. But what if the patient has a lateral compression? Then look for another source of bleeding if the patient continues to be unstable despite effort of resuscitation. It's probably not the pelvis. Another one, if you give the patient 4 units of blood because the patient has pelvic fracture and shock, and the patient is not improving, then you need to do angiography and embolization for probably a major arterial bleed in the pelvis, like the superior gluteal artery. So how do you know that the patient is resuscitated? You can do it by several ways. The 2 ways that come in the exam, either the base deficit from -2 to +2, or the serum lactate level. The normal is less than 2.5. The blood lactate is the endpoint of anaerobic metabolism. The blood level of lactate reflects a global hypoperfusion that's directly proportional to the oxygen debt. The base deficit is a direct measure of metabolic acidosis and indirect measure of blood lactate level. Both correlate well with organ dysfunction, mortality, and adequacy of resuscitation. For the sake of an exam, you need to measure 2 things for adequacy of resuscitation: the blood lactate and the base deficit. Normally, the body utilizes energy from breakdown of glucose. Each molecule will give us 2 pyruvate molecules and 2 ATPs. This occurs when you have oxygen. If you don't have oxygen, the pyruvate will attach to the protons and give lactic acid, which is a strong acid. Lactic acid is a pyruvate that's holding on protons. When the lactate gives away the protons attaches to bicarbonate, and then you will have base deficit. When the patient is acidotic, it means the body is experiencing inadequate tissue perfusion. Then it undergoes anaerobic mechanism to create some energy, and the lactate is created. The more the lactate level, the more will be a base deficit. You want to be aware of under-resuscitated patient. Be aware of the compensated shock. The patient will be under-resuscitated with normal vital signs. That patient will be at increased risk for huge, exaggerated systemic inflammatory response. The IL-6 plays a major role in the inflammatory response. IL-6 or interleukin-6 is secreted by the T cells and by the macrophages. It stimulates the immune response, especially during infection and during trauma. The interleukins are a group of cytokines, which is secreted proteins and signal molecules. The IL-6 warns the body and the immune system against the source of infection or inflammation. It is like sounding the alarm bell or raising attention to something is wrong. And for these patients, we do damage control orthopedics. For managing this patient, you can always do the emergency things such as pelvis binder or angiography. You release the compartments. You do fasciotomy, even bedside fasciotomy. You will consult vascular surgery for vascular problems. You will prevent further injury of the spine by immobilization of the neck. You will reduce a knee dislocation, for example, or a hip dislocation. You will reduce fracture that will give you soft tissue compromise, like an ankle fractures. You will deal with open fracture by doing a little IND and splint the fractures. You will improve the alignment. You will give antibiotics. You will give tetanus if needed. And you probably will do either traction or external fixation for the femur. Timing of the debridement of open fracture did not really affect the infection rate. Early administration of antibiotics will decrease the rate of infection. And then we're going to take the patient to the operating room as soon as possible after the life-threatening condition is treated and destabilized. And that is still debatable. If the patient is adequately resuscitated, you will take the patient to the operating room and you're going to fix the fracture, or you convert the fractures that is stabilized by external fixture to IM rod. Orthopedic management of polytrauma patient. Management of polytrauma patient will have certain principles, and these principles are: the pelvis is an emergency, compartment syndrome is an emergency, open fracture is urgent, hip and knee dislocations are emergencies, femur fracture could be a problem. Then assist the resuscitation. If they are under resuscitation, you're going to do provisional stabilization. If they are adequately resuscitated, you will do definitive fixation. Imaging and multiple trauma. Usually we get the C-spine, the chest, to see if there is an aortic problem or lung problem, and we get the pelvis. Nowadays, routinely, most of the centers are getting CT scans. The unstable pelvic fracture, the patient is unstable and the pelvis is unstable. The pelvis is an open book type. then you will apply a binder or a sheet around the pelvis immediately. If the patient in the operating room, you will do external flexor. Hemorrhage is the leading cause of death in pelvic fracture. Closed head injury can occur in lateral compression fracture. However, in open book ABC type 3, you have the highest rate of blood loss, blood transfusion, and mortality. Mortality correlates with shock at presentation. The compartment syndrome is another area that you need to deal with emergently. Pain more than the injury, you have a swelling of the extremity. Pain with passive stretch of the compartment. Paresthesia in a specific area, it usually occurs later. The pulses, the pallor occurs later. Usually it is too late. You got to have high index of suspicion. Don't wait for the 5 Ps. The 5 Ps indicate well-established compartment syndrome. You need to diagnose the compartment syndrome early because you need to do the fasciotomy before 6 hours. Otherwise, you may have dead muscles. Pressure measuring can be used to diagnose or to confirm the diagnosis of compartment syndrome when the situation is not clear. And if the pressure is 30 mm mercury or within 30 mm mercury of the diastolic pressure, then you will do fasciotomy. The delta P, which is the perfusion pressure, is the one that currently is used frequently. The delta P is the diastolic pressure minus the compartment pressure. If it is within 30 mm mercury, then that is critical, then you need to do fasciotomy. The anterior compartment is the one that's usually involved in the leg. When performing fasciotomy in the lower leg, the classic 2 incision technique is commonly used. The lateral incision is made halfway between the tibia and the fibula, and you will release the anterior and the lateral compartments. Be careful not to injure the superficial peroneal nerve. The medial leg incision is made 2 cm posterior to the tibia. Then you open the superficial posterior compartment and the deep posterior compartment. We're going to talk about open fractures. Classification of open fracture. Grade 1, 1 centimeter or less. Grade 2, 1 to 10 centimeter. Grade 3, more than 10 centimeter. Grade 3 is divided into 3, A, B, and C. Grade 3A, there is adequate tissue for closure or coverage. 3B, extensive periosteal stripping requires soft tissue coverage, a local or distant flap. Grade 3C, vascular injury requiring repair or amputation. Segmental fractures are considered grade 3 even if they have a small wound. The most important thing to remember with open fractures is to give immediate IV antibiotics. Give the antibiotics immediately, as soon as possible. Delay in giving the antibiotics will result in more infections. Increased infection rate occurs when antibiotic administration is delayed more than 3 hours. You will continue the antibiotics for 48 to 72 hours following the index procedure. You will do urgent and adequate debridement to prevent infection. The timing of the irrigation and debridement is debatable. There is no difference in the rate of infection identified between early and late debridement. The 6-hour rule doesn't have a lot of support in the literature. You will do early soft tissue coverage within 7 days because that decreases the infection rate. So what kind of antibiotics do you give? You will give first generation cephalosporin for grade 1 and grade 2. You will add aminoglycoside for grade 3. So you will give first generation and aminoglycoside for stage 3. You will add penicillin if there is gross contamination, if there is a farm injury, if there is bowel ischemia, and if there is water contamination, use fluoroquinolone. Or if there is a critical piece of bone that's missing and it is found, you can sterilize it and you can put it back and fix it. It's probably better to give it a try rather than throw it away. You can use antibiotic solution or betadine to sterilize it. If there is a metaphyseal defect in the bone and a big gap, you may use cement with antibiotics. Also, the wound vac is very helpful in the treatment of open fractures. How about when the patient is pregnant? Trauma is the most common cause of maternal death in pregnancy. Problems between pregnancy and getting x-rays, especially in the first trimester because the fetus is at risk. But when the patient is more than 20 weeks, position the mother in the left lateral decubitus position to avoid compression of the aorta and the inferior vena cava by the uterus, which will decrease the cardiac output by about 30%. If the spine of the patient is okay, then she should be in the left lateral decubitus position. Resuscitation should focus on the mother. The fetus can die from maternal shock or maternal death. Another problem in multiple trauma is the DVT. You need to know about the Virchow triad, you need to get the patient out of bed, early mobilization, mechanical compression devices, in surgery, in bed, in the hospital, which might prevent venous stasis and increase systemic endogenous fibrinolytic activity. You can also give low molecular weight heparin. You can use a filter in a high-risk polytrauma patient and in other specific indications. DVT is approximately 60% in pelvic fractures with a high PE incidence. Exam is more helpful to diagnose DVT. There will be pain and swelling, and the Homan sign is not specific. What if you get acute PE? We will have increased ventilation pressure, acute onset of dyspnea, tachypnea, and tachycardia, and decreased oxygen saturation with increased PaCO2 and tidal CO2 gradient. If this happened in the operating room, do damage control orthopedics and get CT scan of the chest. Stabilize the patient, and you probably will place a filter in some indications. How about traumatic amputations? You need to control the bleeding. It is the severity of the soft tissue injury that have the highest impact on the decision-making process, whatever you amputate or not. Absence of plantar fixation is also important, but it is not an absolute contraindication to reconstruction. The outcome, especially return to work, is not really different between amputation and reconstruction of the extremity at 2 years follow-up. Now we talk about general trauma complications. Fat embolism syndrome. It occurs in about 10% of multiple trauma patients. It occurs in up to 2% of isolated fractures. It usually occurs between 24 to 48 hours after the injury. The difference between fat embolism and pulmonary embolism is the interval between the injury and the symptoms. Fat embolism occurs earlier than pulmonary embolism. The mortality rate of fat embolism is about 20%. This inflammatory response to all embolized fat globules. It can be mechanical, like in the marrow, or metabolic. Early fracture fixation and destabilization decrease the incidence of fat embolism. How to diagnose it? You need to have one major criteria: hypoxemia, CNS depression and confusion, petechial rash, pulmonary edema. The last three are called the classic triad. The oxygen level will be below 60. 4 minor criteria: tachycardia, pyrexia, retinal emboli, fat in the urine or in the sputum, thrombocytopenia, decreased hematocrit, dyspnea and anxiety, and tachypnea. Treatment is ventilatory support with high level of PEEP, in addition to prevention, and have a high index of suspicion. Another complication is acute respiratory distress syndrome, ARDS, which is an acute lung injury, which leads to refractory hypoxemia, decreased lung compliance with poor gas exchange. Patient will have pulmonary edema with diffuse infiltrative changes on X-ray. It's caused by acute endothelial damage. It has a high mortality rate that can reach up to 50%. Patient will have dyspnea with resistant hypoxia. Rule out cardiac pulmonary edema or bilateral pneumonia. The treatment is PEEP, ventilation, and steroids, and also prophylaxis with early stabilization of long bone fractures, especially the femur. Patient can die from sepsis or from multi-system organ failure.